welcome to everyone who has joined us already and all of you who are joining right now. We're so excited to extend our latest opportunity to meet up with all of you in a webinar format. As you all know, we love to take every opportunity we can to update you about exciting developments in melanoma and other forms of skin cancer, both research and treatment. And when Moffitt research leads to new developments and treatment options for our patients, well, that's what we really want to talk to you about. And in the past year or so, we've had not one, but two situations where entirely new types of treatment for melanoma were pioneered, tested in clinical trials that were led by Moffitt surgeons and resulted in FDA approval and new available treatments for our patients with different types of melanoma. So we're going to talk about two situations where the Moffitt surgeons you're going to hear from were the leading investigators on national studies that led to FDA approval of new and innovative treatments for melanoma. The first one, here's just a brief disclosure, of course. We're not giving you medical advice. We're just telling you about the latest developments. And of course, we welcome any questions you have. You can put them in the Q&A section. We'll collate them and try to answer as many of them as we possibly can. Next slide. I'm Vernon Sondak. I'm the chair of the Department of Cutaneous Oncology. I've met many of you, but not all of you. And welcome to everyone. Our first of two speakers is Dr. Amod Sarnaik. As I said, he's a surgeon here with me in the Department of Cutaneous Oncology. He's been a pioneer in tumor infiltrating lymphocyte, or TIL, therapy, and he's going to tell us all about how that went from the laboratory to now an FDA-approved and commercially available treatment for advanced melanoma. Amod?
Thank you, Vern, for the kind introduction. I'd like to start off with my first slide, which, as Vern alluded to, covers what goes on in the lab and how it got translated into patients. This is the overall treatment schema for adoptive cell therapy with tumor-infiltrating lymphocytes we refer to as TIL. If you focus your attention on the left, number one, at the 12 o'clock position, a patient presents with metastatic melanoma. That disease is unresectable for intent to cure. A portion of that disease is excised in the operating room, signified by the hand holding the scalpel, and that tumor is transported into the lab where the tumor-infiltrating lymphocytes, or the immune cells that infiltrate into the tumor, can be extracted from the tumor itself. Now, these cells have migrated to the tumor in the patient and are trying their best to reject the tumor. But unfortunately, tumors do develop means of avoiding immune cell destruction. But in the laboratory setting, one can coax out the TIL and grow them to tens of billions in number, signified at the 3 o'clock position in the figure on the left. These TIL can be seen under the microscope growing, dividing, and actually chewing up the tumor. And then these TIL can be further selected or even perhaps modified to boost their activities in their ability to kill the cancer cell, shown at 6 o'clock in the figure. Once we identify the TIL that seem to be working best, they can be pulled together and subject to a large-scale expansion, shown at the 9 o'clock position on the left, grown to very large numbers, tens of billions in numbers, that can be reinfused into the patient. Now, this treatment, I wish it were as simple as that. It has been shown that the treatment requires a chemotherapy. The purpose of this chemotherapy, which is given right before the TIL infusion, is designed to prepare the patient so that they can receive the TIL and have the TIL engraft. The chemotherapy temporarily reduces the white blood cell count of the patient so that the competing TIL don't have to fight with the endogenous immune cells. And then after the cell transfer, it does require a high-dose interleukin-2 or IL-2. Now, there are some downsides to the treatment. The manufacturing can take 6 to 8 weeks. It's rather complex. The treatment is associated with some side effects, which are unique to this treatment, which I'll discuss. And it is a bit expensive. However, this has been shown to demonstrate actual patient cures, even in the setting of disease that has not responded to traditional therapy. This treatment originated at the National Cancer Institute in Bethesda, Maryland, and then was implemented at other elite centers, including Moffitt. Next. So this treatment is not exactly for everyone. There are certain criteria for patient selection. We typically don't treat patients over the age of 75, although exceptions can be made. Patients have to be evaluated to have acceptable performance status. They have to have enough reserve to tolerate the side effects. Furthermore, the testing also includes a cardiac or heart stress test, as well as pulmonary or lung function testing. So there are certain parameters that have to be met. Patients can't have active spread of disease to the brain, and this is due to the risk of bleeding that can be induced from the chemotherapy. However, patients can be treated even though they're spread to the brain, as long as those tumors in the brain get radiation first. And then finally, the tumor must be able to be removed with acceptable side effects. So there are some times when the tumor is just too central in the patient and we can't get the tumor out without too many side effects from the surgery. Having said that, there have been excellent clinical results in early phase trials, and this led to a multi-center trial. It's actually a multinational trial that was championed by Moffitt, and it included a centralized manufacturing strategy. So the cells were actually grown at Moffitt and then shipped to satellite centers. So Moffitt really was a pioneer in getting the treatment off the ground and actually FDA approved. Next. And this is the treatment option. The TIL, the drug that's the bag of cells that are called TIL, the name of it is lifileucel. And this is the treatment outline. Patients come for screening. In step number 2, they get surgically excised, and the tumor then gets shipped to a centralized manufacturing facility. For the clinical trial that led in part to the FDA approval, Moffitt was part of the manufacturing center, but now there's centralized manufacturing that is off-site. But the process was validated where the tumors resected locally, shipped in a special container, delivered to the manufacturing facility where the TIL are propagated, and then frozen down, shipped overnight back to the manufacturing center, or the treatment center. The whole processing time takes about 6 to 8 weeks total. The manufacturing time itself takes just over 3 weeks, and then extra testing needs to be done. And then looking at step number 3, the patients undergo chemotherapy, then the TIL infusion at step number 4. Step number 5, the patients get high-dose interleukin-2. This occurs in the hospital. Patients stay in the hospital anywhere from 5 to 14 days for recovery, and they're discharged thereafter. So this treatment schema allows centralized manufacturing so that the treatment can occur at the local centers rather than the patient having to travel to the place where the manufacturing occurs. Next. So the treatment does have side effects. When I approach patients, I like to split them up to short-term and long-term side effects. The column on the left shows the short-term side effects. That includes fever, chills. What's most pronounced is low blood pressure, low oxygen, and sometimes malfunctions of major organs like the kidneys. But fortunately, these side effects are temporary and generally reversible, especially when the treatment is given by a team with experience like we have at Moffitt. On the right are some of the long-term side effects. Above the red line are the side effects due to the chemotherapy. That can be fatigue, neuropathy, as well as damage to the bone marrow. Below the red line are some long-term side effects, and these are related to what I call friendly fire. The TIL are supposed to reject the tumor, but sometimes can cause some side effects by affecting the normal organs. People can have some inner ear function that leads to high-frequency hearing loss and some imbalance or disequilibrium. There's also can be a loss of skin pigmentation called vitiligo, as well as inflammation of the eye swelling called uveitis. But the bottom line, though, is that this is a single cycle of treatment, so patients do not need to get multiple treatments. So after the treatment is over, there are very few new treatment-related adverse events, especially after 3 months, and that's one of the benefits of this treatment. Next. So this slide's a bit technical. It's called a waterfall plot. It shows the response for patients at a specific time point. The y-axis is change in baseline. So at the center, near the center of the graph, the 0 line is where the tumor targets neither grew nor shrank. A positive deflection above the 0 line indicates the tumor grew. A negative deflection below the 0 line indicates the tumor target shrank. So you can see by looking at the proportion of this graph, the majority of patients, 80% of the patients, had some degree of shrinkage of their tumor burden, indicating the effectiveness of this treatment. And this was in the registrational clinical trial that was led by Moffitt. Next slide. And this slide's a little bit busy, so I highlighted with the red box the important data points for this slide. This is the effectiveness of treatment. This, again, is the clinical trial that included patients that had disease that did not respond to traditional treatments. And that traditional treatment for melanoma is immunotherapy called PD-1 blockade. So this is effectiveness in PD-1 treatment refractory or treatment disease not responsive metastatic melanoma. We enrolled 189 patients, 153 got treated, and the objective response in these patients was 31%. That landmark 31% response rate is vastly superior to alternative treatments when the patient's disease has progressed on the frontline treatment of PD-1 antibody. And what's important is that these responses were long-lasting or durable. If you look at the patients who responded on this trial, more than half of them went on to continue their response over 2 years of a follow-up. The other thing is the centralized manufacturing was successful. The manufacturing success rate was 95.8%. Next. This slide shows survival information. The graph on the left is overall survival, and the graph on the right is progression-free survival. In both of these graphs, the y-axis indicates the percent overall survival with the x-axis indicating time. So for each graph at the very left, at time point 0, 100% of the patients are alive on the left, 100% of patients are without progression on the right. The blue line indicates the landmark result at 12 months. So on the left, the overall survival of this group of patients, and remember, these are disease that did not respond to traditional treatment, the response rate, the overall survival was at 50%. And on the right, the 12-month landmark of progression-free survival was about 30%. What you'll note from both of these graphs is it doesn't go down as a straight line. Over time, the graph starts to plateau. And especially looking at progression-free survival on the right, keep in mind that these patients are not going on to any additional treatment unless there's progression. It looks like there's a very nice plateau of the curve at just under 30%. So this indicates that 30% of patients achieve long-term benefit from this treatment, as there really isn't much late progression beyond the 12-month time point. The other thing to note is that the median time that patients developed a response was quite quick, 1.5 months, and that was actually at the first disease assessment. And at the median study follow-up of more than 2 years, the median duration of response was not reached, with almost half having a response lasting beyond 16 months. So the results of this trial led to FDA approval because these patients, unfortunately, don't have any other very good treatment options like this treatment is. Next slide. Well, we're not satisfied with these results. We're always looking to improve upon things. And there are 3 different clinical trials that are underway in order to improve the response rates for our patients. One includes, of the tens of billions of TIL, can we possibly select the subset or the fraction of TIL that mediates the immune response? So there's an ongoing clinical trial at Moffitt where we're selecting the neoantigen, which is the target that the tumor expresses that the TIL recognize. We can select those neoantigen tumor-specific TIL by a high rapid cell sort and concentrate the TIL, probably get more responses with less side effects. Additionally, also open at Moffitt is a clinical trial where we're gene targeting the TIL by knocking out PD-1, which is the gene that's the target of the first-line immunotherapy. Patients do get resistance, and in part that could be related to upregulation of this target, which can actually be knocked out genetically. And one can also insert cytokines or other inflammatory proteins into the TIL to boost their effectiveness, and that's another ongoing clinical trial. So the bottom line from this slide is that efforts are underway to improve the results that we have achieved. Next. So just to conclude, TIL therapy is available at Moffitt Cancer Center and can salvage patients after disease progression on prior lines of immune-mediated treatment like immune checkpoint blockade. That's the PD-1 antibody for metastatic melanoma, and it's FDA approved. While the toxicity is relatively high, for the most part, it's temporary, and means of boosting patient responses are underway that may include gene modifications and/or selection of the TIL. And I believe that's my last slide, so I'd like to thank you for your attention.
And thank you, Dr. Sarnaik, for that excellent presentation. We will have questions later on in the program. So if you have questions, feel free to put them into the Q&A box. You can see obviously why we're excited about TIL therapy. We continue to do research, but it is now commercially available, even outside of a research project. And to get something so complicated from the research world into standard practice is a major achievement, but it's not the only achievement we've done. We took another unusual, technically complicated um, uh, treatment process that you're about to hear about from Dr. John Zager, another one of our surgeons in Cutaneous and the chief academic officer for all of Moffitt. He's been a pioneer in percutaneous hepatic perfusion since its earliest days and shepherded not one but two major clinical trials that ultimately led to FDA approval of this technology for one kind of melanoma. And Dr. Zager is going to tell us all about that right now. John?
Yeah, thank you, Vern, for the nice introduction. Next slide. So what I'm going to talk to you all about is, as Dr. Sondak mentioned, uveal melanoma. Uveal melanoma is a melanoma of your eye. It's an intraocular tumor in adults. About 50% of those patients with ocular or uveal melanoma are going to eventually develop metastatic disease where the disease spreads. And unlike cutaneous melanoma, where the disease spreads mostly to lymph nodes as a first stop, but then can spread anywhere else in the body, uveal melanoma usually spreads directly to the liver. So about 95% of the cases, the liver is the organ that receives this metastatic spread. Historically, once a patient has uveal melanoma and it has spread to their liver, the median or average survival after that event is less than 1 year. So we did lead a few trials here at Moffitt and using a technique called percutaneous hepatic perfusion, which I'm going to describe in a few slides, is now FDA approved, and that's a minimally invasive way of isolating the liver, where all this metastatic disease is, and circulating high-dose chemotherapy right at the tumor, right into the liver, with very little of this very high dose of chemotherapy getting elsewhere in the body. Next slide. So here you can see a schematic of the procedure, and the patient on the right has a catheter going through the artery in their groin, the femoral artery. That catheter is snaked up to the liver, and it sits in the hepatic artery, the artery that feeds the liver. This is the catheter that we use to give the chemotherapy into the liver. Another catheter, again, minimally invasive, just catheter insertions, or like an IV, has a double balloon on it, and this is inserted into the femoral vein, the vein in the groin. Those balloons are placed above and below the liver, and they are blown up, effectively isolating the liver from the rest of systemic circulation, as you can see with this little cutout of the patient diagram in the middle. So after we isolate the liver, we perfuse it with this high-dose chemotherapy. The balloons prevent the chemotherapy from going anywhere else in the body. We actively pump out the chemotherapy with a cardiac bypass pump. It is filtered, as you can see in the left side of the diagram here, through two proprietary filters outside the patient's body. All the chemotherapy goes in the blood, go through those filters, and then the chemo-filtrated blood goes back into the patient through a third catheter that's placed in the internal jugular vein in their neck. So basically, we have the ability to perfuse the liver with super high doses of chemotherapy, clean the blood, collect the blood from the liver, filter the blood outside the patient, and through cardiac bypass, reintroduce all the blood to the patient through a third catheter in the patient's neck. So all it is 3 catheter insertions. So it's a pretty cool procedure. Next slide. And we did lead an international effort to bring this to FDA approval, and it is also CE mark approved in Europe. And this was a phase 3 trial led by Moffitt. We were the lead international site. We put the most patients on the trial and certainly have a great team with it, great experience. Next slide. So the FOCUS trial, which is the name of the trial, started out as a trial versus best alternative care. So we would randomly assign patients either liver perfusion or best alternative care, at which point was one of 4 different treatments. It eventually moved to a single-arm trial just looking at liver perfusion because patients were realizing worldwide that, that the liver perfusion arm is available in Europe as it's CE mark approved, and they were leaving the trial if they got randomized to best alternative care to go pay for liver perfusion in the countries in Europe that had adopted the technique after the first phase 3 trial back in 2012. So once we talked to the FDA and the FDA agreed to move it to a single arm, everybody gets liver perfusion, we ran with the trial and finished it off with just a single arm liver perfusion method. So every patient could receive up to 6 PHP treatments, percutaneous hepatic perfusion. This was repeated every 6 to 8 weeks. Any patient with progression inside their liver or progression with disease outside the liver were discontinued from study treatment, and all patients were followed until they either were lost to follow-up or died of disease. Patients were imaged with CTs and MRIs of the liver, brain, chest, abdomen, and pelvis every 12 weeks. And the primary endpoint was the response rate as assessed by an independent review committee that wasn't familiar with which patient got how many procedures, etc. Next slide. So here is when we first started the trial and we had a randomization trial. We randomly assigned them either PHP, which is again percutaneous hepatic perfusion, or one of the 4 other arms you can see there, which is chemoembolization, again, another method of getting into the liver and embolizing or cutting off the blood supply to the tumors. Pembrolizumab and ipilimumab are immunotherapies, 2 different types of immunotherapy, and dacarbazine is a standard of care melanoma type chemotherapy, which is not used very often, but sometimes used in patients with ocular melanoma that's spread to their liver. Next slide. But as I mentioned, this trial was eventually amended to just percutaneous hepatic perfusion. And we've had a bunch of presentations and publications since the trial has ended, one of which you can see right here, which was presented at ESMO conference in Europe this past fall. Next slide. I'm going to break down those results a little bit more clearly for you. So here we looked at those patients that were randomly assigned. So we did do 91 patients had PHP, 32 patients had best alternative care. So there is some data there where we can compare liver perfusion to best alternative care. And it's worthwhile trying to understand if PHP is better than any alternative care we have. And as you can see here, when we look at complete responses, we had almost 8% of PHP versus 0% of best alternative care complete responses. About 30% or close to 30% PHP versus 12.5% BAC, best alternative care, partial responses. So we're talking about over 36% overall response rate for liver perfusion versus 12.5% overall response rate for best alternative care, which is a tripling of the response rate. Next slide. So disease control rate, is it enough to just get a response? Or if we can stop the tumors from growing, is that a win? I think in this disease where I showed you the first slide where the median survival is less than 12 months, sometimes just controlling the disease and preventing them from spreading or growing or more liver being involved is a win in these patients. And here you can see The liver perfusion patients had about a 74% best alternative, disease control rate, versus half of that best alternative control had a 37.5% disease control rate. So you're talking about a doubling of disease control in the treated population that received liver perfusion. Next slide. And what about progression-free survival? This was the primary endpoint of the study, looking at how we can control disease in the liver and preventing it from further progressing, getting bigger, getting more nodules in the liver, or even progressing outside the liver. And as you can see here, these are called Kaplan-Meier plots. The light blue line is the liver perfusion group. The dark blue line is best alternative care. And you can see here again, there was a tripling of the median progression-free survival response in favor of the liver perfusion group. So 9 months median progression-free survival in PHP versus about 3 months median progression-free survival in best alternative care. Again, a tripling in favor of the percutaneous hepatic perfusion arm. Next slide. How about overall survival? So overall survival was also in favor, again, that light blue line on the graph on the right is further to the right. So when it's further to the right, that's better in Kaplan-Meier plots. If the lines were perfectly on top of each other, then we would say there's absolutely no difference. But as the lines move further to the right, the ones that are further to the right are better. So if we look at the graph on the left, the dark blue line are those patients who had a complete response. Obviously, their survival is going to be the best, followed by the lighter blue line, which the ones who had partial response, their survival will be the second best, then stable disease, then patients who progress right off the bat. So when we break down survival by response, you can see that those who have a response do much better, obviously, than those patients who have stable disease, who do much better than those patients who progress right through therapy. Next slide. We also presented a sub-analysis of these results at ASCO, and the next couple of slides will break this down a little bit as well. Next slide. So what about progression-free survival and overall survival by extent of liver involvement? Is there a difference if we have 0 to 25% of the liver involved versus 25 to 50%? Well, based on this and just looking at liver perfusion patients, there's no difference in progression-free survival. Those curves are overlapping on the left. You can see whether the liver is highly involved or little involved, meaning 0 to 25% versus 26 to 50% of the involvement of the liver. But overall survival seems to be in favor of those patients that have less liver involvement, meaning the 1 to 25% liver involvement. Again, that lighter line is pushed to the right, which shows that if we can treat these patients earlier with lower burden of disease, we probably could extend their survival, which is one of my messages to patients and to other referring doctors is let's get these patients on PHP, liver perfusion, as early as possible once we know that they have metastatic disease, because I truly feel, and we have some data to support that we could increase their survival chances by treating them early when there's less liver involvement rather than treating them as second, third, or fourth line. Next slide. However, in the next 2 slides, I'm going to also show you when we break down progression-free survival and overall survival by other factors. This slide you can see by presence of extrahepatic disease. Some patients come to us and they have extrahepatic disease, meaning they have a nodular in their lungs or a lymph node in their retroperitoneum behind their liver, or maybe some subcutaneous disease elsewhere. And while they do have disease outside the liver, limited extrahepatic disease does not take you out of contention for a liver perfusion. As long as that I can direct some sort of treatment to this extrahepatic, the disease outside the liver, in between usually the first and second liver perfusions. You remember they're separated by 6 to 8 weeks, we will still perfuse a patient's liver because that's really where the life-threatening maximum amount of disease is. So if you have 1 or 2 lung metastases, or if the patient has 1 or 2 lung metastases or a lymph node metastasis, we can either irradiate those metastases or excise them in between liver treatments. These 2 slides show that if you have hepatic-only disease versus hepatic and extrahepatic on the left, that you might have a better overall progression-free survival if you just have liver disease. However, overall survival is pretty much the same, knowing that we can try to treat some of these extrahepatic nodules and still perfuse your liver. So we're attacking the tumors both inside and outside the liver with no poor outcomes in terms of survival. Next slide, please. And then, as I talked before, can we still treat patients with prior lines of therapy? Sometimes they come to us after 3 or 4 previous lines of therapy that they have progressed through. Now, while I do believe that there is a survival benefit to treating these patients with a lower burden of disease, and I do believe that if you fail multiple prior therapies, the odds of you having higher burden disease in the liver because you're failing, you're progressing, you're failing again, and you're progressing, the odds of having a higher burden of disease in your liver are greater. These slides do show that it doesn't matter if you've had prior therapies or not, that percutaneous hepatic perfusion will be able to salvage some of these patients and have a similar survival and progression-free survival. Next slide. So here you can see kind of a summary of the last couple of slides where we're looking at the best overall response rate in terms of extrahepatic disease, prior therapy, and extent of liver involvement. And there really was no difference in these response rates between all these categories of breaking down the subgroups. Next slide. So we also looked at our own series. Now, the previous slides were the worldwide cases where Moffitt was the lead site internationally. We put the most patients on. But between the first phase 3 trial that was finished in 2012 and the second phase 3 trial that started in like 2018 and finished in 2023, there was only one place in the United States that was offering percutaneous hepatic perfusion as an expanded access or compassionate use, and that was Moffitt. So about 5 or 6 years in there, we were doing this on patients, and each patient that came to Moffitt that needed this procedure, we would have to write a new protocol, submit it to the FDA, get the FDA's approval to treat one patient as a compassionate use. Each patient had to have their own protocol. But for years, we continued to offer this because we did believe that this was a worthwhile therapy for the patients, and we knew that there was another phase 3 trial coming, and we were crossing our fingers that we would help push this over the finish line, and eventually it would get FDA approved, and lo and behold, it was approved. So we were able to gather our own data and kind of look at it under various different ways. So one of the first publications that we've had since the FOCUS trial has ended is, again, really kind of narrowing down on should we use PHP early? Should we be looking at it as a first-line therapy versus second or third line? And Helena Gali was one of our medical students, and she took this project on as one of her summer Cutaneous Oncology research internship projects. So next slide. And here we looked at a retrospective review of, again, that 15 years of experience of patients treated with PHP. We looked at the line of therapy, whether it was PHP versus immunotherapy versus chemoembolization. So we just looked at 3 different therapies, first or second line, in which would produce better results for these patients. Next slide. And in this small retrospective review, we found that PHP, again, looking at hepatic progression-free survival, progression inside the liver itself, appeared to be better when compared to immunotherapy, which is the red line, liver-directed therapy, which is chemoembolization and radio bead embolization, versus the blue line, which is percutaneous hepatic perfusion. Again, hepatic progression-free survival was, by first-line therapy, seemed to be the winner when we compared all three of these therapies. Next slide. When we looked at second-line therapy, meaning that immunotherapy is now second-line, liver-directed therapy was second-line, PHP was second-line. These patients were treated previously. Again, it appears here that PHP outperformed immunotherapy or liver-directed therapy in terms of progression-free survival inside the liver. Next slide. We also looked at overall progression-free survival. Are we losing the battle if we just concentrate our treatment in the liver? Are these patients just blossoming with metastatic disease outside the liver? Is it worth it? But again, we looked at this and it seems that percutaneous hepatic perfusion controls the disease and outperforms liver-directed therapy or even systemic immunotherapy in terms of first-line therapy when looking at overall progression-free survival. Next slide. And as second-line therapy when looking at overall progression-free survival. So even as a second-line therapy, with these patients being previously treated with other therapies and recurring with disease outside their liver, it still looks like PHP does a better job at controlling the disease than immunotherapy or liver-directed therapy. Next slide. And then when we looked at survival status, again, first line versus second line, here it's a little different than this survival that we saw on the focus trial. Here we look at second line therapy actually looks like it does better. That line again is shifted to the right than first line therapy in terms of overall survival. However, statistically, if you look at the p-value, it's 0.1. And anything that's greater than 0.05 is not statistically significant. So even though there is a difference in the curves here, it doesn't seem to be statistically significant from each other. So there is an absolute benefit to it, but not a statistical benefit to it. Next slide. So in conclusion, when looking at PHP, percutaneous hepatic perfusion, we used melphalan, which is this high-dose chemotherapy. It shows statistically significant improvements in overall survival, disease control rate, progression-free survival, and overall survival when compared to any best alternative care in the patients with metastatic uveal melanoma. PHP for metastatic uveal melanoma to liver offers better hepatic disease control when used as a first-line therapy compared to immunotherapy or other liver-directed therapy, at least 2 times longer hepatic progression-free survival with first-line PHP compared to immunotherapy or other liver-directed therapy. PHP continues to offer improved hepatic and overall progression-free survival advantages when even used as second-line treatment compared to second-line immunotherapy or liver-directed therapy, and patients still favorably respond to PHP despite the presence of previous therapy, despite the presence of disease outside the liver, and despite the presence of a greater extent of liver involvement, we still can treat these patients and they still have favorable responses. And I think that's my last slide. So thank you very much for your attention and allowing me to come show our exciting data to you all tonight.
Thank you, John, and Amod as well. Thank you, all of you, for listening. We've got some great questions, and I want to answer a couple of the more general ones first before calling on our speakers for some of the specifics. The first question is, uveal melanoma seems rare. What other rare cancers are being researched and treated at Moffitt? Well, uveal melanoma is rare. It's only about 1 to 3% of all melanomas, and there are about 100,000 melanomas in the United States every year. We see about 2,000 to 2,500 new melanomas a year here at Moffitt. But uveal melanoma isn't even close to the rarest kinds of skin cancers that we see. We see all sorts of cancers that arise from the skin, rare cancers that arise from like the sweat glands and other parts of the skin besides the standard basal and squamous cancers, and melanoma, which arises from the melanocytes of either the skin or the eye. So if it is one of the absolute hallmarks of our group here at Moffitt that we try to take on the rarest, most challenging situations. Another very rare situation is melanoma in children. And that's one of my particular interests and something we've done a lot of work with. So there's pretty much nothing too rare for us to take care of here. Let's give another, here's another question. I'll throw it out to both of you because it's a very, very important thing to mention. How long does a treatment or a new medication take to go from the start of an experiment in the lab to actually being used and approved by the FDA? John, Amod?
I'll go first, Amod. I'm sure Amod is going to have a similar answer, but for percutaneous hepatic perfusion, I got involved in the first phase 3 trial, which was after, obviously, phase 1, phase 2, and any laboratory in 2007. It finally was approved in the FDA in 2023. So we did 16 years of percutaneous hepatic perfusions before we were able to get that, as you can see, very powerful and beneficial treatment approved by the FDA. And I got involved after that phase 3 trial was already underway, very early in the phase 3 trial, but there were other centers who were already involved. So it takes a long time for some drugs. And that might be a little abnormal, doesn't always take 16 years, but for this one, it took 16 plus years.
Well, I think, unfortunately, TIL may have that beat. In some form, TIL therapy, formerly known as LAC or lymphocyte activating killer cell therapy, originated in the mid-1980s. So it was an extremely long time. With regards to TIL in its present form, we've been doing this at Moffitt since 2010. It required a long time because there was a lot of immunology that needed to be worked out. And the actual start of the registrational trial happened in 2016. And we just got approval this year. So still takes too long, in my opinion. I think it was ready to go. All the science in the lab got worked out, and it still took about 8 years to attain FDA approval. I think there are a lot of safeguards to the approval of new drugs, which are extremely important. But I think there also is a lot of red tape that could potentially be shortened. So I think I'll leave it at that.
Fair enough. Now, here's one last general question. How does a person find out if they're eligible for a clinical trial?
Well, I'll go first with that one. It's a very tough thing because there isn't a really good central repository of available clinical trials. Patients tend to go on clinicaltrial.gov, which is a website that, as the name implies, is run by the government. It will list eligibility criteria as well as disease site. That's where patients go to get an idea if they're eligible or not. At Moffitt, I think we do have resources. I think Mark posted his contact information. I oftentimes will talk to patients on the phone to kind of review eligibility when it comes to trials that I'm aware of or I'm involved in. But I think in general, patients do start off with clinicaltrial.gov. I think there's also local oncologists may also refer patients as well. John, what do you have?
Yeah, I don't have much to add. I agree. I do spend quite a bit of time talking to patients on the phone about trials that I might be involved with or heading up to see if they're a candidate And there are some online and Moffitt-based resources to look up if you are a candidate or if a potential trial seems to fit the disease that you have, and then you contact somebody at Moffitt and they will go over your candidacy as a patient for that trial.
And obviously, as you've seen, the patients who get onto these clinical trials, they're carefully selected, so we really know that it's safe for them to be on the study, but also that we'll learn something from their participation. These patients were all screened at Moffitt before going on the clinical trial. And our physicians, whether they're surgeons, medical oncologists, radiation oncologists, dermatologists, are all very keyed into the clinical trials we do. No one of us can remember all of the eligibility for all of the trials, but we have an entire team of clinical trial coordinators dedicated just to cutaneous. It's one of the things that really makes us such a strong department for doing these kinds of research, because we have our own clinical trial personnel. And when we have somebody who might have uveal melanoma or refractory melanoma that might be a candidate for TIL, they can come with the list of trials and the criteria and say, hey, check this. We have to do this blood test. We have to do this x-ray, and make sure all that gets taken care of. All right, let's move on to a couple of other questions. First of all, and this is a great question, you've talked, Amod, about TIL as sort of the last ditch effort. Do you believe that TIL will ever become a standard of care for early melanoma? And if so, how far away are we from that?
So as things stand right now, the registrational trial, TIL was used as a very late line of therapy, and there's a lot of vulnerability there. When patients present with advanced disease, they're difficult to treat no matter what modality you choose. And one of the inherent weaknesses of TIL is the time it takes to manufacture. I wish it were shorter. In its present form, it's too long, in my opinion. To get TIL to early line, say front line, TIL has to demonstrate vast superior efficacy compared to the standard of care, which is IV infusions of immunotherapy, more often dual checkpoint or now even triple checkpoint immunotherapy. And that bar is pretty high. So for TIL to beat that bar, we're talking at least a 50 to 70% response rate. There's going to need to be some substantial improvements in the immunobiology of TIL. And I think one way that can be done is to genetically modify the TIL to be more effective, potentially speed up the growth as well as the tumor reactivity. And these are ongoing areas of research, but I think we need to have gain an understanding of the tumor immunology in order to really get to that level. As things stand right now, though, TIL can be used in the second line after progression on frontline immunotherapy. There was a clinical trial conducted in Europe, which have a little bit more restriction in terms of what patients can get and when. That trial basically randomized patients to TIL versus second-line immunotherapy, which is the CTLA-4 blocking antibody John mentioned, ipilimumab. And the results of that trial indicated a superior objective response rate, as well as a superior progression-free survival of TIL. Response rate was 49% in the second line, compared to only 20% for the control arm, which is ipilimumab. So the problem, though, is that TIL needs to get a more broader application. And right now, there still are relatively few centers that have the expertise to manage the patients and their side effects. So that's another thing that we as a group are working on.
Great. Here's a question for you, John. What is the connection between uveal melanoma and the liver? It's unusual, to say the least, for any form of skin cancer to just so consistently spread to one part of the body. Where are we in understanding that? What are we doing to further our understanding of that?
Yeah, that's a great question. And I think there's a little lack of understanding why the ocular uveal tumors go directly to the liver. One could say that there is a lack of lymphatic vessels in the eye, so it doesn't drain to lymph nodes like cutaneous melanoma. But then you could say, okay, so it gains access to the vascular system, which would be venous access, and it has to go through the lungs first before it gets pumped out by the heart to the livers as arterial blood. So why doesn't it just get stuck in the lungs like some colorectal metastases do or other tumors? And it's a very interesting question. So there's something unique, and I'll be honest, I don't necessarily understand the exact adhesion molecules or whatever, but there's something unique about those uveal tumors that bypasses the lungs and gains access to the vascular system, bypassing the lungs, goes to the heart, gets pumped out and stuck and filtered by the liver and presents as metastatic disease 95% of the time in the liver. It's a very interesting phenomenon, but for one reason or the other, it bypasses every other organ and just sticks in the liver. So there must be something specifically some sort of adhesion molecule or whatnot on uveal melanoma cells that are specific for sticking in liver parenchyma, the liver itself.
And of course, if we could understand that, maybe we could block it. We could block that molecule and prevent the liver seeding from occurring in the first place. This is why we do what we call bench to bedside to bench research at Moffitt. The research process starts with an observation just like that. Hey, why is this happening? We see it as clinicians. We ask the scientists. They say, I don't know, get us some cells. We'll try to maybe put a mouse model together, do some test tube work, see if we can figure it out. And if we can, then see if we can block it. Then we'll give it back to you to try in patients, bench to bedside and back to the bench to tell them, here's what's working, here's what's not working. That's really been one of the things that's made our entire program here at Moffitt successful in our melanoma and other skin cancer research. So that is also called translational research because we're translating something to the scientists, and then when they discover something, we're translating it back into something we can give to people. Amod, in addition to being in charge of our TIL program, you're the clinic medical director. So I'll ask you this general clinical question. What stage of melanoma patients do we accept in Moffitt? When should a patient be referred to cutaneous clinic at Moffitt when they have melanoma?
So Moffitt is recognized as a melanoma center of excellence, and we treat patients from stage 0 through stage 4. And in general, although melanoma seems to increase in its incidence year over year over year, I think that the general community surgeons, for whatever reason, tend not to be quite as familiar with the treatment of melanoma. So we do get referrals for early stage melanoma from all over the state of Florida, including the East Coast and the Panhandle, all the way through southern Georgia, Alabama, and even Mississippi. So our doors are always open to treat patients from stage 0 to stage 4.
And I will say, we will take everybody at any stage from the beginning to the end. We would love it if we could see everyone right at the start and give everyone the most treatment options. We have clinical trials that we've been doing. In future, maybe we'll dedicate a future webinar to some of the clinical trials we've done in early stage melanoma to improve the surgical treatment, the radiation treatment, minimize the side effects of early stage treatments as well. I think it's one of the most tragic things that we see when someone had an early stage and highly curable skin cancer, melanoma or otherwise, and they come to us later on after their best and easiest treatment options were missed. So we'll take everybody. We get many patients referred direct from the dermatologist right to us, but we also take many people after they've been treated locally and when they really are in need for some cutting edge treatments. So we haven't been able to get to every single question, but we did a great job getting to most of them. I wanted to save just a couple of minutes for Mark Ketterer, who we work with very closely from the Moffitt Foundation. He specializes in supporting us in the cutaneous department, and he's just going to say a few words about what the Moffitt Foundation does and how you can help with our efforts in the research and treatment of melanoma.
Thank you, Dr. Sondak, and thank you all for joining us this evening. And thank you to our esteemed panelists here. The Moffitt Foundation is committed to supporting the research and the cutting-edge treatments pioneered by the Cutaneous Oncology Department. This evening, you heard about 2 life-saving treatments that Moffitt has played an integral role in. And the research related to these treatments was made possible by the generosity of donors who believe in the efforts of our physicians and researchers, some of you who have joined us this evening. So first and foremost, I want to thank you. But philanthropy will continue to play a key role in the research outline this evening and the ability to improve these treatments that you've just heard of in order to reach more patients. A few of you had asked, is this only for late stage? Hopefully we can make something that it's not just for once the disease has progressed. So please reach out to me to find out how your philanthropic support can make an impact on Moffitt's mission and contribute to the prevention and cure of cancer. Thank you for being here this evening, and I'll let Dr. Sondak go ahead and close it out.
I will, but there is one last question, and Dr. Sarnaik has volunteered to try to answer that. Amod?
So there's a question about artificial intelligence or AI and how these have impacted these 2 treatments. And I'm sorry to say that we have not yet been able to include AI with regards to TIL, but this is an area of unmet need. One of the things that's known that when you study the TIL that reject the tumor, they tend to target individual mutations that are not shared between tumors of different patients. And there aren't that many TIL clones that recognize targets, very, very few. So out of the tens of billions of TIL that we generate, it's really the 4 or 5 TIL clones that recognize 4 or 5 different targets that seem to mediate the vast majority of rejection. But one way to move TIL higher up, maybe towards the frontline setting, is that you can harness AI to target mutations that are shared between tumors. For whatever reason, this doesn't happen in nature or naturally, but if one can rationally design either T-cell receptors or chimeras of protein where one chimera binds to a mutated version of the tumor target that's shared between tumors, and then the other cytoplasmic domain activates the T-cell, one can theoretically design a custom-made off-the-shelf product that can be either introduced into TIL or perhaps even used in some other means that's non-cellular to reject cancer. And I think that is one potential way where we can beat cancer, but we're going to need a lot of bioengineering help. And one of the things that is tough to do is to predict how proteins fold and bind and interact based on amino acid sequence. But AI can potentially help us make those predictions and design those custom molecules.
And of course, this is something that nobody even thought about 5 or 10 years ago. How could we predict what kind of immune structures would be necessary to kill cancer? Moffitt has very strong programs in bioengineering and in mathematical oncology, 2 of the unique programs in our cancer center that very few other cancer centers around the country have. And we're very happy to be able to collaborate with all of those researchers on melanoma research. They work on a lot of different cancers, but we've been excited to work with them. So that's a great glimpse of the future, another unique aspect of working at a cancer center like Moffitt. Again, we're delighted that all of you could join us, and this might be a first that we've ever ended right on time, but I'm really excited to say that we are. So thank you all and have a wonderful evening.